it does seem to be all hands to the deck. So far, I've been very impressed with the response of the medical profession in general. I think one of the things that's driving a lot of the fear is the feeling that we're not being provided with adequate protection.
Hello and welcome to our podcast Pager. I'm George Milner.
And I'm Stan Dale.
Tune in to hear us talk with some amazing people about the subjects changing medicine today.
From stem cells to mapping the brain and medical ethics, we hope to give you a glimpse of the bright future ahead through discussions with some of the people making it happen. Hey everyone, and welcome to this week's episode of the podcast. This week, Dr. Rohin Francis talked to us about the current COVID-19 pandemic and its effects on the NHS. Rohin's a practicing cardiologist, and he's also currently doing his PhD at UCL. He's very involved in science communication, and he runs a really great YouTube channel called Medlifecrisis, where he's put out a lot of really fantastic videos on COVID-19, as well as a lot of other medically related topics. The conversation we have focuses on how the hospitals are preparing for the surge in patients that's coming, and sort of what the state of doctor morale is at the moment. And later on, we get into some of the reported effects the virus has on the heart. And finally, we end on a discussion about the lockdown in the UK, which at the time of recording had just been enacted, and the future decision-making which is going to have to be made between protecting the economy and potentially protecting human life. Due to a few technical issues, we lost the first couple minutes of the recording, and so we really just jumped straight into the meat of the episode straight away. Without further ado, we really hope you enjoy it. Let's talk about what the attitude amongst sort of the healthcare professionals in the hospitals right now is about what's going on. What is the status at the moment? How worried are people about the coming weeks? And where are people expecting the breakdown in care to be?
Yeah, it's clearly a very stressful time at the moment. I can segue our last conversation into this one by saying that doctors' WhatsApp groups are awash with fake news at the moment, and I'm in several WhatsApp groups of different groups of registrars in various regions, and all the same stuff goes around. I mean, 80% of it is jokes and memes, which is great, but we're all hearing these stories about doctors being intubated and doctors being mugged for their hospital ID, things like this, which all those things have turned out to be fake news. And, we're all medically trained and we're not engaging a little bit of fact-checking before passing these on unwittingly. Now, I'm not going to have too much of a go about that because I think what it's reflective of is there's a lot of fear at the moment. Many of us have got friends and colleagues in Italy that we've been in contact with, and there's a long tradition of Italian doctors coming to the UK to work, so many of us have contacts there. So we've heard firsthand some of these accounts, and it's just crazy. And for whatever reason, culturally, geographically, we're closer to Italy than China, and I think there's been a lot more information coming out of Italy than China. It seems to have become a lot more real since it's hit Europe, which of course is it's disappointing that it took that and we weren't alert to it earlier. I work in the Essex Cardiothoracic Centre, so just outside London, and it certainly seems to be the case that London has been much worse affected so far. We're just waiting for that to sort of filter out. I'm sure it will. But certainly talking to friends in critical care in London hospitals, in different specialties, everybody's been affected so far. And the numbers that are published are significantly lower than reality. There's a bit of a lag time.
How has your role sort of shifted since this crisis began as a cardiologist? How is what you're doing now different to what you were doing?
I think where I am, we still have yet to see the brunt of it. So the changes we've made have all been proactive. They've been things that we've done in preparation, which is, of course, the way it should be. So we've cancelled all elective surgery, all elective angioplasties and everything like that. Clinics are cancelled. And this is the case, I think, in most hospitals in the country at the moment. Study leave has been cancelled nationally. Annual leave kind of put on hold. We've got kind of redundancies built into our rotas now. So clearly this week I'm off, which unexpectedly, it was terrible timing because I was about to go on a weekend of days and then a week of nights, which has led to, of course, a few snide comments from my friends that I engineered this. No comment, but these things are going to happen. That several of us have already been off, both amongst the consultants and the juniors. So we're having to be very flexible and adapt and fill in for each other. And some of us are going to be redeployed. We've had conversations about that. I personally haven't yet so far. In terms of the kind of structure, I can speak for cardiology in that we've set up a COVID lab, which has got its own it's a pre-existing cath lab, but it's one that had its own self-contained air conditioning. So that was designated the kind of dirty lab. And this is a lesson that we learned from China, where they'd have clean teams and dirty teams, and then a clean lab as well. So we're trying to get ready in advance. One thing that I am yet to do myself, because I've been in isolation this week, but I will prioritize as soon as I get back, is to get familiar with the donning and doffing procedures. So to put on all our PPE before getting into the cath lab, getting the procedures correct, because obviously these are things I'm not familiar with, to make sure I'm doing everything properly to protect myself, protect other members of staff, and protect patients, of course. So lots of things to learn.
Mm. Yeah, absolutely. And I suppose it brings up this question of what is the difference between having hands available and having useful hands available? And I suppose it makes me wonder, how is the health service restructuring? So clearly intensive care is going to be the name of the game for saving lives and expanding your capacity to provide that. How do you repurpose, where is the health service going to look to bring people in who will be most easily trained to deal with this? You've obviously probably got anaesthetists who will be high up on that list, but could you sort of expand at all on how the health service is going to be restructured if the pyramid is sort of shifting up, so to speak?
Yeah, I'm not sure anybody has answers to these questions. I've heard rather mixed accounts on what the kind of approaches are. I've heard that recently retired doctors are going to be called back. Doctors from the private sector are going to be sort of commandeered. I know that some of my friends have been asked to fill in forms with their competencies about whether they could help in areas where they're not normally working. And these tend to be doctors who are sort of more outpatient based, like dermatologists and things. So they filled in these forms saying kinds of things they'd be comfortable doing, or even...
That's really interesting.
Yeah, I mean...
And sort of how do those forms work? Is it like a 1 to 10 scale of your confidence, or a yes or no?
I got to say, I don't know. I haven't been sent one myself. I'm not sure where they're coming, whether they're just sort of local to their trusts. I know that a friend of mine who has just come out of research where she was doing a lot of basic science. Actually, she's a doctor, but she's said, I'm happy to work in the clinical pathology lab because I've got all these skills of pipetting, and if that's going to be more useful, then I'm happy to go there. So I think we're all willing to. I've got an unusually a large amount of ITU experience, so I'm quite happy to work as an ITU SHO, for example, or something. Wherever the demand is. Yeah, it's going to be a very interesting time in terms of how we can maximally utilize the skills on offer.
And that's going to be a lot of information to go through, I imagine. And it doesn't sound like there's a very uniform approach to working out who's actually going to be able to help at doing what.
I guess the best thing to do would be to try and address this on a trust by trust basis, and hospitals can reallocate within. I don't know. I feel just even in the few days that I've been off, I feel like I'm out of the loop, and I think that's how quickly things are changing at the moment.
Changing on the ground.
So I don't know if these conversations have taken place in my trust in terms of people being pulled into A&E or ITU, for example.
Yeah, it's sort of at the risk of being a bit hyperbolic. It sort of reminds. Have you seen Lord of the Rings? You know, in the Two Towers when they're getting ready to defend Helm's Deep and they're giving the little kids the axes.
Yeah.
Sort of what giving a giving a psychiatrist or a dermatologist some sort of role in an ICU.
A laryngoscope. That's their axe.
You mentioned something else which I thought was really interesting. You've, like you said, been off for a few days because you had symptoms. Do you think different people are responding differently to this? And what I mean by that is, it's a very hard question for you to be able to speak to, but is there sort of this potentially a divide between some people staring this thing in the face and being like, we're going to war and I'm going to make myself available in whatever ways possible, and some people who are potentially taking, they got a bit of a cough and they decide, all right, okay, I'll be off for 2 weeks then because I have to self-isolate. I don't know if I explained that very well, but do you sort of see what I'm getting at?
Yeah, I know what you mean. I think reactions are coming in all different shapes and sizes. I'm reluctant to think the worst of people. I think if people are feeling scared, it's normally, I don't think for them. I think a lot of people are scared about loved ones, about bringing something horrible home to an elderly relative, and those kinds of fears I think are really real, and I'd never criticize somebody for feeling that way, and other people, very much are kind of bring it on. This is what I went to medical school for, and I'm not sure either is right or wrong. But yeah, I think we're seeing all different reactions. So far, actually, I've been tremendously encouraged by the response of people. Obviously, everybody. I hate this phrase, but it's a good description. But everybody virtue signals online, so I'm taking the online world with a pinch of salt. But just from interactions with friends and colleagues, people really seem to be trying to tackle this in the best possible way and helping each other. And I've been absolutely so impressed by my bosses, who really are taking this seriously and seem to want to prepare as best they can. There's none of this talk about, oh, will I still be able to do my private cases or anything like that. It does seem to be all hands to the deck. So far, I've been very impressed with the response of the medical profession in general. I think one of the things that's driving a lot of the fear is the feeling that we're not being provided with adequate protection.
Yes, I imagine that's. I can see how that would be true. Yeah, basically, just tell me more about morale in the hospitals, and is what people are worried about the lack of personal protective equipment. What are the big concerns?
Yeah, that's definitely dominating most discussions, and there was again a lack of clarity from Public Health England, in that initially they were suggesting we needed a certain level of PPE, and then they downgraded the advice, saying that actually, for the majority of patients and the majority of things, you just need a standard surgical mask. And by this stage, I think everybody is aware that a standard surgical mask isn't really going to offer much at all. There is a sort of undercurrent of fear that I think means that people are erring on the side of caution, even when we are doing high risk procedures, so these kind of so-called aerosol generating procedures, things like intubation, non-invasive ventilation, bronchoscopy. So this has been something that's certainly on our minds, that we want to be adequately protected. Now, in my trust, so far everybody's being fitted with the appropriate mask, but I can't say the same for a lot of other places. And that, I think, is really unacceptable. I think there are increasing accounts of doctors dying in Italy and China, and healthcare professionals really in the firing line. So I feel like...
Well, it was really one of the big breaking stories coming out of China, wasn't it? That there was, I can't remember the guy's name. There was a doctor who basically was whistleblowing and saying that people were dying of coronavirus, and the government really tried to shut him up. And I think he ended up dying of the disease himself. Sort of like this awful story.
Yeah, that was Li Wenliang, and that's one of the sources of another very upsetting conspiracy theory that people allege that he was killed by the Chinese Communist Party because he was trying to speak up. Um, let's assume that it was a disease that killed him, and even right at the that was back in January, February that we learnt of his death, and I think he was just 34, and so that should have rung alarm bells then. Is that why was this young, healthy doctor dying when we're told that this is a disease that only is affecting the elderly and the infirm? And I think as time has passed, it's apparent that isn't the case. That young people are affected less commonly.
Yeah,
But
I've heard that sort of there's stories coming out of Italy and the States now of people between the ages of 20 and 40 having to be intubated and becoming seriously sick.
So the CDC's stats that they've released, again, everything changes on a day-to-day basis. So by the time this goes out, it'll be out of date, I'm sure. But the 20% of admissions to critical care in America for COVID-19 so far have been 20 to 44 years old. That obviously is going to be skewed towards the young because older patients are less likely to be admitted into intensive care. But we know that so far in the UK, the average age of admissions to intensive care for COVID-19 is about 60, so 62. So these are not particularly old patients. And if we go by the American figures, a fifth of patients being admitted to critical care are young. And just yesterday, there was a cardiology fellow who's lost their life from COVID-19, and I think again they were in their early 30s with no pre-existing medical conditions, not in the UK. So I think that's been a big. Coming back to your first question about misconceptions, I think that's been a hugely problematic misconception that this is just some boomer remover. It's just taking out old people, and it's nothing for young people to really worry about. I think that's led to a lot of a lack of volition to do things.
Yeah, absolutely. And I think there's some interesting evidence which they've looked at people who had SARS, the original SARS in 2003. They've looked at their sort of cardiovascular and respiratory health 10 years later. And, setting aside the number of people that might die from this coronavirus, the evidence suggests that there could maybe, in the future, having looked at a similar virus, be serious effects on your long-term health, even if you're not killed. And I suppose it also speaks to the fact that, what you're saying about the misconceptions, that's a really damaging misconception in that it certainly doesn't help us all cooperate when you start dividing it up into, well, fundamentally, I'm not going to be affected badly by this disease, so I'm not going to worry about spreading it, even though other people might be badly affected. But I thought.
Yeah, I think that's just been a huge mistake in trying to motivate people, in that the risk to us all is not from the virus itself, but it's from all the knock-on effects. So even if the virus is going to be a self-limiting illness for you or me, if the healthcare system has been completely brought to its knees and is completely ineffective, and you cross the road and get hit by a car, sorry, I should have given myself in that hypothetical. It's not very nice to say you're in an accident. But if I've been hit by a car, then ordinarily I'd just go into a trauma center and be treated without problem. But now the whole health service is going to be affected. So everybody's risk is going to go up if they have any kind of normal medical problem that normal people get. And I think that's been another misconception, that these deaths are replacing other deaths. Everything else still happens. All the other causes of mortality and morbidity are ongoing. And as you say, morbidity, which has been talked about far less. Everyone's focused on the case fatality rate, and you've got all these armchair epidemiologists doing their calculations. I have calculated it's only going to be 1 million dead worldwide, and I can live with that on my conscience. I don't want the stock market to be affected. It's all the associated effects on people's health that doesn't result in death, which is going to be incalculable.
And like we said, I don't think we even fully understand the scale of the effects it might have on people who aren't in an obvious risk category. I think that information's still yet to become really obvious. And some of the questions I have are like, why are so many more people dying in Italy than were dying in China as sort of a proportion of the people who are infected. And I'm not sure anyone has particularly good answers to those questions.
No, I mean, I've seen a few suggestions for that. One being case fatality ratio is obviously related to the denominator. So if you're testing fewer people, your case fatality rate will be higher. But another suggestion I heard was, Italy has a well preserved and quite a lot of elderly people in the population. So if you've got more older people, you'll see a higher rate of death. I don't know, the veracity of those things.
I read somewhere that there might be effects that this virus might be having on the cardiovascular system. I'm not sure we fully understand what those are, but could you speak at all to any new literature which is coming out or any evidence clinically that this is affecting the cardiovascular system specifically?
Yes. I still need to look into this in a bit more detail, but we do know that there is a cardiomyopathy described from some of the early Chinese cases. One of the first fatalities that was reported seemed to have a sort of catastrophic cardiomyopathy, and it appears that some of the sickest patients do develop this cardiomyopathy. It is overwhelmingly a respiratory disease. I think it's important to emphasize that the vast majority of pathology is in the lungs. Some of these patients, this is now kind of more anecdotal. When I say anecdotal, I mean that there are published case reports, but still they are just case reports of patients who seem to have this biphasic pattern to the illness. So they have a period of apparent improvement and then sort of deteriorate again. And normally that is a sort of ARDS picture, but there has been described a cardiovascular collapse in some patients as well. And it's thought to be secondary to this cardiomyopathic process. So what's actually occurring? Well, now we've seen a few case reports in America where I've actually seen the ECG traces, and they're presenting like ST elevation MIs. They're kind of barn door ST elevation on an ECG. The ones I've seen have all been anterior, but then they're taken to the cath lab and they have clear coronary arteries. Now, sometimes you'll have ST elevation and you'll have unobstructed coronary arteries, and it'll be that the clot has passed and you're not seeing anything there. But I don't think this is the case we're dealing with here. We know that in cardiovascular populations normally, when you have this picture of an acute coronary syndrome presentation with unobstructed arteries, in about half of those cases you get a myocarditis, and that's actually the cause, and that's giving the patient chest pain and ECG changes, troponin rise, but their coronaries are okay. And so myocarditis is about 50% of those cases. And
that's really just an inflammation we're speaking about.
And that's an inflammation within the tissue of the heart, within the muscle of the heart. And it's through cardiac MRI that we're picking up much more of these cases than we used to, because it doesn't show up on an echo. So it was thought that maybe these patients in COVID-19 are getting a myocarditis type picture. However, as far as we can tell, there has not been any sort of biopsy proven or post-mortem specimens confirming a myopericarditis, inflammation of the muscle or the lining around the heart, pericardium. So that may not be the case. What instead may be happening is we're getting obstruction of the microvascular, the microcirculation in the heart. So the epicardial vessels, the big main coronary arteries that you see on an angiogram, have got nothing obvious blocking them, but all the tiny vessels that don't show up on an angiogram are getting blocked up. With what we don't know. There's reports of sloughing of the endothelial cells, and so maybe they're being sort of shoved down the coronary arteries and into these tiny vessels, and maybe that's what's causing a heart attack type appearance. But we don't know. Maybe it's inflammation within the coronary arteries and the microcirculation itself.
What sort of markers are upregulated sort of when someone is infected with coronavirus? I think I saw some data looking at pro-inflammatory cytokines. When it comes to inflammation, do you reckon that could be playing a causative role in causing this pathology?
Yeah, I mean, certainly. In terms of the immune response, there's evidence of a large IL-6, interleukin-6, and interleukin-1 response. So this may supply or support the theory that this is those very small vessels being blocked. It's clearly a highly inflammatory process. Whether it's a kind of classical myocarditis that we were expecting, or whether it is this diffuse obstruction of the microvascular circulation with these sloughed cells, or whether actually this is something more like a Takotsubo stress cardiomyopathy in response to critical illness. I don't think we know. That probably wouldn't be my top candidate, because I think we'd probably when you get a stress cardiomyopathy, the prognosis tends to be a little bit more favourable. So we'd tend to see that the hemodynamics improve, and we probably would have seen some characteristic echocardiography changes. So it's probably an inflammatory process, either in the small vessels or the muscle itself.
I mean, so you're saying that potentially this cardiovascular pathology could be a big contributor to the mortality, at least in some patients?
I'd not say a big contributor to the mortality overall. I think that's overwhelmingly all respiratory.
Sorry. I meant in patients who present with the cardiovascular pathology, that puts you at much greater risk of being badly affected by the virus.
Yeah. Whether that led directly to the cause of death, I think is much less likely than the respiratory system, but I think it is a pretty important consideration. And I think that's reflected in the fact that, the two groups of patients at highest risk in terms of pre-existing medical conditions are those with cardiovascular and respiratory pre-existing diagnoses. There's this interesting signal for hypertension, which has been a source of a lot of debate, in that normally we don't really get too worried about hypertension as a past medical history. If you're assessing somebody for their risk before a major anesthetic, for example, hypertension isn't something that rings alarm bells. But it seems to be a predictor of a poorer outcome from the patients we've seen so far with COVID-19. And whether that is because a lot of these patients are on angiotensin receptor blockers or ACE inhibitors has been the source of a lot of debate, but I don't think there are any clear answers at the moment. You've got some people suggesting that losartan could be protective. Losartan is an angiotensin receptor blocker. And you've got others saying that you should come off your losartan. And some of my friends' parents have done exactly this. They've responded to some sort of scary message from who knows, and they've stopped their antihypertensives. So I think, again, we're getting into difficult territory here if we're making judgment calls based on incomplete information. For what it's worth, the cardiovascular bodies so far, like the European Society of Cardiology, have issued a statement saying if you're on these antihypertensives, there's no reason to stop taking them at the moment. So that's my line at present, is that there's no reason to change somebody's medication from what we've seen so far. But clearly it's an area of interest.
Could you explain a bit like why the lack of testing is an issue?
I probably won't give the best epidemiological answer.
That's never stopped us before, Rohin. Always charge ahead.
From a healthcare professional's point of view, I think the lack of testing is a major hindrance in terms of having your workforce working to their full capacity. So, say for example, me, I I'm going to be off for a week at least, but I'm feeling fine, so I should be able to go back at the end of my 7 days. Now, we don't know if I've definitely had the virus. I was questioned by a few people. I asked if I could get my hands on a test. I haven't been offered one. A few of my friends have. It's a bit haphazard. So I don't know if I have got any degree of immunity when I go back to work. If I did, I'd be quite happy to volunteer to work in that dirty lab that I was mentioning earlier. I'd hopefully be able to fill in as friends go off sick. If I get another febrile illness in 2 weeks, at the moment I'll have to go off again for a full week. Whereas if we know it's just a cold, then I wouldn't have to take that entire week out, and my family wouldn't have to self-isolate for 2 weeks. And so if we know that people have had the two different types of tests being talked about, one is during the active infection, which is available now, then the other, which is not available, but we hope it will be soon, is an antibody test to see if you have had the infection before. So we're just going to lose much more of the workforce than we need to if we didn't test everyone. From a wider epidemiological perspective, I'm sure someone trained in public health and epidemiology would give a better answer. But clearly, if we're not measuring the problem, we're not going to know exactly the scale of it. If we find out that 10% of the population has been infected and the vast majority of them were completely asymptomatic, then that gives us a whole new insight into what the pattern of this illness is. And we assume that there is asymptomatic spread, but unless we know really how many people are infected and recovering, we don't know exactly what we're dealing with.
It's hard to sort of fully understand the virus if you don't understand, everyone who's been infected.
And the health authorities, the WHO has been very clear in their message that it was literally test. They're saying that that's the way to deal with this, and we know because we've got a model to look at. We know that South Korea took that approach of very intensive testing, tens of thousands of tests per day almost, or per week, and we've got the most accurate case fatality rate from them, and they've also been able to stem the new cases. So we've got something to look at. I mean, that's why there's a lot of.
Out of interest, what was the rate? What was the rate recorded in Korea?
0.6%.
Okay.
So that is, if you take that as a maximum, because they've done the most testing and they've got 0.6, so it's likely to be lower than that. Which 0.6 is still about 6 times more than seasonal flu, but it's clearly much lower than the 3.4% that the WHO had published several weeks ago. I mean, that's probably only 3 weeks ago or 2 weeks ago, but it seems like months ago now. Things are changing so fast.
Yeah, the difference in those two values, I'm sure, changes everything, really.
Yeah, but again, I think it's important to say that people get a little too focused on the numbers, particularly the case fatality rate. I think it can distract from looking at the overall picture. Some numbers are really useful. So, there have been some fantastic data visualizations. I found the daily graphs published by the Financial Times very useful, which track absolute numbers, not corrected in any way, just so you can appreciate epidemic growth in each country and sort of compare them. But in terms of the case fatality rate, it's a number that can be that can change from place to place. So even within different regions in China, you'll have very different case fatality rates, or over time. So if you look at the case fatality rate for China, and that's how it's often reported, that Chinese case fatality rate, that's not really telling you anything at all, because the case fatality rate in the early few weeks was something like 20%. It was horrendous because they didn't know what they were dealing with. It was all taking them by surprise. And then if you look at cases after the 1st of February, then the case fatality rate falls right down to, I can't remember exactly what it was, but something like 1%. So that's one number that I think is sometimes thrown about which is a bit of a distraction. I can't remember what the question even was now. Why did we start talking about that?
I mean, that's all right. And I suppose the other unique thing about what you're doing, Rohin, is that I'm sure you interact with a lot of people from the public who are worried about this current outbreak. And so you might be quite well equipped to say what you think. What do you think are potentially the biggest misconceptions out there about the current pandemic?
Oh, well, I mean, I think misconceptions come in different flavors. So sometimes when people talk about misinformation related to the coronavirus, they kind of talk about very silly conspiracy theories, like this being manufactured as a bioweapon in a Chinese lab, or all these kinds of silly things. And that's fine. It's obviously important to discredit that kind of stuff. But then there are misconceptions held by people with scientific training, and that may be to do with the likelihood of finding a cure anytime soon. And there's a lot of misinformation flung around by medical practitioners or people within the medical sciences when they really should know better. Things that are overhyped, and misconceptions about the whole issue itself. Well, I guess that is a spectrum from people who believe it's all an overreaction and it's really not such a big deal, and people who are operating that the worst case scenario is the most likely outcome. And the most recent episode that you have uploaded at the time of recording this, which was with David Spiegelhalter, was a fascinating discussion, I thought, about the public's understanding of risk when it comes to something like this. And it's a really difficult concept for anybody to get their head around. And I'm not trained particularly in statistics, so I've really grappled to try and understand what people mean when they say, well, seasonal flu kills this many people. Why is that different? And these are the kinds of questions that I think are pretty difficult to answer and to communicate. So, yeah, with the coronavirus, there are many misconceptions out there.
That being said, I think you did a really good job in your last video of giving a pithy explanation for why the risk associated with coronavirus to the population and the effect it's going to have on all of us is distinctly different from, as some people are arguing, sort of the risk that there is because of flu or our risk of disease throughout a normal year.
Yeah, that's right. And again, this is based on David Spiegelhalter's work, and it was interesting actually comparing what he was saying in that episode with George, because I assume that he wrote this piece afterwards, because he said, as I said, a footnote to this, that thank you to a friend for asking me to look into this, because I think it sounds like he'd changed his attitude compared to when he was on your show. But yes, apart from childhood, where risk is high as an infant, sort of straight after birth, and then falls, and you're at your safest in your life when you're at primary school. That's your lowest risk of dying in any given year. And then it goes up. There's a bit of a bump in late adolescence and early 20s, particularly in guys, and I think we can all guess what that is, increased risk of mortality. But after that, it's pretty linear all the way in a logarithmic plot. And as you say, your risk of death roughly goes up by about 9% each year, which was slightly misinterpreted by quite a few of the YouTube commenters. So I'll just make it a bit clearer here. It doesn't mean your risk of death is 9%. It just means whatever your risk of death is at the age of 25, it'll be 9% greater at the age of 26. So you're at a very low risk of death at that age. So it's still a very low risk the following year. But when you get to 99, your risk of death in that year may be 50%. And then the following year, it'll be 59%. So the statistics from a widely cited Imperial College produced paper about the coronavirus epidemic, on an epidemic scale, but the pandemic as a whole, looked at the risk of mortality in each age group. And that's they've published it in 10-year age groups, so 20 to 29, 30 to 39, so forth. And if you plot for the seventh year out of that decade, which has got some clever statistical explanation that I can't now recall or wouldn't be able to communicate anyway. But if you plot it on the seventh year of each decade, it actually matches that linear logarithmic line for overall lifetime risk. But the big problem is you're condensing that a year-long risk into what we assume is going to be a few weeks. So you're essentially exposing the healthcare service to a year's worth of risk, but in a very short time. So I think that was I didn't come up with any of that, but that was a really interesting and clear way of communicating what a huge challenge this is. A much more visual way of communicating it is just seeing what's going on in Italy and now even in London.
And I think that's a really good way of taking another look at what people mean by flattening the curve, because that's really speaking about the same thing, stretching out the amount of time the health service has to deal with everyone who's going to get this virus. Thanks for that. It's a good way of thinking about it. You mentioned to me when we were chatting before we actually started recording, sort of your next video there was sort of a philosophical slant to this whole thing you wanted to explore a bit more.
Yes, it kind of comes to this wider question. So we now find ourselves at the beginning of what we're told is 3 weeks of lockdown. Looking at my friends' videos from Hampstead Heath and Richmond Park and Trafalgar Square, I'm not sure how much of the lockdown is really being enforced at the moment. But let's put that to one side. There's clearly a spectrum of reactions here between, frankly, people who sometimes come across as sociopaths that are saying, some people are just going to die. Boris Johnson's initial phrase when this started was we've got to take it on the chin, right? And
if you think about what that really means, it's actually quite harrowing.
Yeah, I think. Yeah, and it comes back to misconceptions about what this virus will actually look like. But anyway, there are people at one end who say we should not put anything, we should not stop life in any way. We should just carry on as normal, like as if this is some sort of terrorist attack that we shouldn't let it defeat us because then the terrorists will have won. And this kind of complete devotion to the markets, and then there's the opposite end of the spectrum to just say, shut everything completely. And if you look at some of the projections from epidemiologists, this could be for an extremely long period of time. And Donald Trump yesterday was asked why he wanted to open things up quickly. Was that in response to any doctors on your advisory panel? And he said, well, if it were up to the doctors, they'd shut the whole economy down for 2 years. And it kind of got me thinking that, again, online discussions are not necessarily the best place for nuance, as we've touched on already. And that there seems to be a lot of groupthink. People just go along with the prevailing opinion. And I think in the short term, the more I've understood about it in my complete lay understanding of all of this, it does appear that we need to buy ourselves time by enacting a full lockdown and trying to arrest the rapid spread of this virus. But thereafter, these projections start varying quite significantly in what they advise us to do. And some people are quite happily recommending, 6-12 months of lockdown. And I'm sure they have considered the negative repercussions, but I'm struggling to find where we need to what we need to do. Obviously there's no right answer here, and the philosophical thing that you
that's the thing. Yeah, sorry, go on.
The philosophical point that you sort of said that I was referring to was this kind of what value we place on human life. and it can lead to very ugly, cold-sounding discussions about how much value a life has, an older person's life versus a young person's life, or a young person's livelihood, not necessarily their death, versus an old person's life. And when you start bringing the economy into it, and businesses, and other aspects like mental health, the effects of long-term isolation, it's immensely complicated, and I have no great insights into this at all. It's just I found myself really struggling to know what to endorse, or where I should stand on this, and I still don't know. I feel confident in knowing that short term we need to do something. We can't just sit around and say, oh, let's just let this burn itself out, or just run riot through people. But I think that there are different models being proposed, but unless we put ourselves in the position to enact them, it's all moot. So I think it's clear that we need to act now.
It's a really good question. Like, I mean, like you said, this sort of question really resists simplicity, because once you have effects on the economy, that affects people's quality of life, length of life, in all sorts of really indirect ways. And so there's no real option of, okay, putting in all the different effects on one side versus the other side of a decision, and being able to spit out a number of sort of the cost of human life and happiness on either ends of a decision tree. And so it leaves everyone in a situation where you want to think about this in a way that is going to optimize for everyone's sort of health and happiness, but not knowing how to do that in a way which isn't fully driven by emotion. I don't know. I mean, is there a way that we can approach this whilst we're sort of so caught up in the middle of it?
Oh, well, I think that's a great point. I don't know. We've clearly got a bias in that we are in the healthcare. We're healthcare professionals, and
you're using that term extremely loosely when you're describing me.
You're a professional student, so I think you're absolutely right that people who are in the middle of this, in terms of in positions of power, are really going to struggle to have a frank discussion, because it's so easy to paint the other side as being either completely void of emotion, or to be blinkered to the unintended consequences. But of course, we make these decisions at work quite regularly. When you're considering admitting patients to your last intensive care bed, you have these kinds of discussions. The most fantastic job I ever did was the heart transplant job in Papworth, and these are the most conscientious, caring, wonderful physicians that I worked with in the transplant team. But they had to make some really, I don't mean to say this as a pun, but they had to make some really heartbreaking decisions in terms of resource utilization, because hearts are something in extremely short supply. So you have to make a judgment call on who you think is going to do best with a heart. So I was really fascinated to see this kind of dichotomy between someone who I would describe as incredibly caring, and then having to be very cold and clinical about certain decisions. And if you have that discussion publicly, people will misunderstand. And likewise, if you have the discussion about what to do in response to the coronavirus, people are going to misconstrue what you say. And so I never would suggest that anybody arguing against a very aggressive shutdown long term is a sociopath or anything. I mean, that side of the debate clearly does attract sociopaths, but I'm not trying to depict anybody saying that as one, because, as you say, there are huge effects. I mean, one of the first things I thought about is the people who we're talking about saving, the elderly and infirm, are the exact same people who are going to suffer most from the countermeasures as well. We're saying that there's an epidemic of loneliness in the UK, and then when a real epidemic strikes, then the treatment for that is loneliness. And I just found it sort of very perverse. So there are these huge effects which I'm not sure we can even predict at the moment. We're just going to have to see what happens. So I'm kind of maybe naively thinking we enact this lockdown now for a short period of time, but I think we need to come up with some other solutions because the British public just won't take it for too long.
Well, I mean, one thing I'd like to say before we sort of wrap up recording, at least, is firstly, I'm really grateful and surprised you've given me so much of your time. I really appreciate that. And secondly, you really have my admiration for everything you're doing, both to communicate what you can about the virus. And I know you're not an epidemiologist, and also in what's sure to be a trying few weeks coming up, working as a doctor in clinical practice.
No. It's been an absolute pleasure, and the appreciation is absolutely mutual here. I'm really impressed with the podcast you guys have created.
No, it's been an absolute pleasure, and you've definitely done a fantastic job of, especially giving us real insight into what the attitudes are like in the hospitals right now, how doctors are feeling about what's coming, and where the potential pinch points in providing care might be. So, thank you. Yeah, thank you again.
Not at all. And I mean, stay in touch. I'm happy to keep you posted about things.
Thank you for listening to the Pager podcast. If you've enjoyed it, then head to Spotify or iTunes to hear more.
As ever, we'd love to hear what you think, and you can reach us via our Facebook page or by email. See you next time.